Good morning, everyone. Welcome to Pediatric Grand Rounds. As always, join us if you can. It's a little icy today, but we are in the Mill Mountain Conference Room, and thank you for joining us online. Today's presenter is Dr. Brooke Jensen. She's one of our third-year pediatric residents at Carilion. She completed her medical school training at Texas Tech and will be pursuing a neonatology fellowship at UT Southwestern in July. While here, she served on multiple committees, including the Respiratory Committee, GMEC Committee, PEC, and is currently serving as one of our third-year chief residents. Please join me in welcoming Dr. Brooke Jensen.
Thanks, everybody. I'm going to preface this with, I'm very sorry, my speed of talking tends to correlate with how much coffee I've had. So I have not had enough at this point in time. If I start out slower and speed up, it's probably correlating with that. But with that, let's get started. So my talk today is called Born This Way, Tiny But Mighty, the Preemie Edition. I have no disclosures. What are our objectives? So I have three main objectives today. The first is to review definitions and the prevalence of preterm births. The second is to be identifying complications that may occur secondary to prematurity. And the third is to identify long-term outcomes of premature children. So let's start off with some history. So neonatology history, it actually was in the late 19th century that Europe recorded its highest infant mortality rate of 230 out of 1,000 births, specifically in 1870. Secondary to that really high mortality rate, infant birth rates were falling, and this prompted the infant welfare movement. With that came a lot of research initiative and funding. And in 1878, the Neonatal-Perinatal was developed, and we'll show pictures of that, but that's realistically one of our first incubators that came up. About 30 years later, the Hess incubator was developed, and we'll show a picture of that as well. It's equally as frightening. And in 1922, you had the first unit that was solely for premature infants that has opened. It wasn't until 1952 that the APGAR scoring was actually invented by Virginia APGAR that we still use to this day. And in 1960 was the first time that we realistically introduced the term neonatology and neonatologist. Prior to this, it was primarily obstetricians that were realistically caring for both the infant and the mother at delivery. The term premature nursery was changed to newborn intensive care unit at this point. And we started making a distinction between small infants and premature infants. The difference between those two is prior to this time period, there was no differentiation between a small term infant and a preterm infant. Any infant that was less than 2,500 grams was deemed premature at this point in time. The mortality risk for a 1 kilogram infant in the early 1960s was 95%. And infants of 28 weeks gestation were considered pre-viable. Here are our wonderful incubators. So the Neonatal-Perinatal is the first on the left. And the interesting thing about this is that a Parisian obstetrician actually invented this by modifying a warming chamber that was originally used for rearing poultry. Now, this incubator was able to decrease the neonatal death rate from 66% to 38% among infants that were birth weights less than 2,000 grams. So it was effective despite the terrifying nature of it. The way that it was accomplishing warming these infants was actually by heating oil and using the, facial expression was the same that I had originally.
Were there any horrific accidents in the making of this product?
I'm sure. Somehow it still managed to decrease mortality rates. But realistically, they used ventilation and the current of warm air that heated up these infants. I don't want to know what their lungs looked like at the end of this. No one was cooked that I'm aware of. The Hess incubator was developed, like we talked about 30 years later. And this was interesting because it was actually primarily for the mode of oxygen delivery that they had created this. Previously, they were still using the heating component of the first one, but we were noticing that infants were needing more oxygen, and so it's one of the reasons why the Hess incubator came along. So, we talked about the early 1960s. Another eventful mark in the early 1960s was JFK's son died at 34 weeks with a birth weight of 2,100 grams from respiratory distress syndrome. Secondary to that, there was a whole new initiative of research and funding now into what is called neonatology. So in 1964, the first radiant warmers were developed and put into delivery rooms. They had the first sub-board of examination for neonatal-perinatal medicine in 1975 and the first successful use of ECMO. In 1980, we had the first successful administration of surfactant to a newborn. And in 1987, the NRP, or the Neonatal Resuscitation Training Program, was launched by the AAP, as well as the AHA. It wasn't until 1990 that the FDA actually approved surfactant use in these kids, so about 10 years after the first attempt of surfactant administration was successful. In 1999, the FDA approved inhaled nitric oxide for persistent pulmonary hypertension of the newborn. And in 2000, that mortality risk that was previously 95% in the 1960s is now down to 5%. So a big change in that 1 kilogram infant. Talking about definitions, how do we define preterm infants now? So we're mostly going to talk about the preterm because that's the nature of this talk today. There are multiple definitions as to how to define infants based on their gestational age. However, realistically, preterm is going to be anyone that is born at or before 36 weeks and 6 days from maternal first day of her last menstrual period. So there are a couple subcategories that we're going to talk about today. Late preterm birth is listed on here. That's going to be anyone that was born between gestational age of 34 and 0 to 36 and 6. We have moderate preterm birth, which is going to be 32 weeks to less than 34 weeks. And then very preterm birth and extremely preterm birth, which are respectively less than 32 weeks and less than 28 weeks. There's another classification that we tend to use for preterm infants, and that's going to be based on birth weight. So we have low birth weight, which is the LBW up on there. That's going to be less than 2,500 grams for birth weight. We have very low birth weight, which is less than 1,500 grams, and then extremely low birth weight, which is less than 100 grams. Why is it important? So in a week, on average, in the US, we have 69,000 babies being born. 7,000 of those babies are preterm, and 1,000 of those are going to be born very preterm. So it is relevant and important. Now, why specifically even is it relevant and important in Virginia? Because 1,700 babies are born in Virginia on an average week, and minimum 27 of those are very preterm, and 125 of those are going to be born late preterm. So why are so many babies born preterm? Why is this so common? I pulled the American College of Obstetrics and Gynecology guidelines for any complications that occur during pregnancy. So, and I apologize for the highlighting. These are the most recent updates, and they were highlighting their changes, and I could not pull any that did not have highlighting. But in that left-hand column, that first column, you're going to have placental and uterine conditions, as well as fetal conditions, and then on the following slide, you'll see maternal conditions. The arrows on that right-hand side are any recommendation for delivery prior to term. So the majority of these complications are going to recommend preterm delivery. Same for this slide. And these are including maternal complications as well. So the majority of these, if not at least half, are recommending preterm delivery for any complication. Now, what are some risk factors? That's a lot of complications, right? What are some risk factors for these preterm births specifically? So rather than just having one cause for a preterm birth, it's really multifactorial. There are a lot of options and reasons as to why you could have a preterm birth. We're going to talk about specific factors that are the most common and why they're the most common in Virginia. So in 2021 to 2023, in Virginia specifically, are going to be all these statistics. Preterm birth rates were the highest in women 40 and older at a percentage of 13.4%. Of these women were delivering preterm infants, followed by women under the age of 20. So it's kind of that bell curve. For smoking, approximately 8% of women that were childbearing age in Virginia are smokers. Multiple births are very common for preterm delivery, and compared to 8% of singleton births that were preterm, you had 63% of preterm, of multiple births were preterm in Virginia specifically. Birth spacing is something that's pretty common here to be less than 18 months, and that puts you at risk for having a preterm delivery. In Virginia, 30.8% of pregnancies had a prior live birth that was less than 18 months before that. That's 1/3 of pregnancies. Obesity is also something that is less specifically a risk factor itself for preterm birth, but more correlated with the complications that are associated that cause preterm birth, so hypertension, diabetes. Approximately 34% of women in Virginia were obese in 2022 that were of childbearing age. Health insurance coverage is another important one because only 1 in 12 women, so about 8%, had health insurance coverage prior to pregnancy, which is going to increase your odds of having complications if you're not managing chronic conditions appropriately. There are other contributing factors. We're not really going to go into them too much, but infection, we already talked about diabetes and hypertension, lack of prenatal care, and alcohol and drug use are going to be important. Now, why is preterm birth so impressive and why is it so important? These are the infant death rates that are per the US and per Virginia. So preterm birth specifically is a major contributing factor to infant mortality worldwide. Approximately 2/3 of all infant deaths, so deaths that occur at less than 12 months of age, were in preterm infants. Now, when you look at those deaths specifically, when you correlate the ones that were of preterm birth, we are able to parse out that preterm birth complications are actually the second highest cause for these deaths. Now, birth defects are still number 1, both in the US and in Virginia. However, they were number 2 for both the US and Virginia for preterm birth related complications. And SIDS is number 3, which we recently had that PICU M&M talking about SIDS. I want to point out that Virginia is not doing a very good job with our comparison relative to the US for SIDS deaths. So something to definitely heavily counsel our patients on specifically. Now, what are some common complications secondary to prematurity? We talked about their pretty big cause of death.
Fix the bathroom.
Okay. Some of the early complications are going to be respiratory distress syndrome, PDA or patent ductus arteriosus, early sepsis, neck, intraventricular hemorrhage, as well as BPD, bronchopulmonary dysplasia, and retinopathy of prematurity. With this, the frequency and severity of these complications tend to increase with decreasing gestational age. This was specifically shown in a prospective population study that was done in France. I'm not going to bore you with the details, but realistically, severe intraventricular hemorrhage, severe BPD, severe retinopathy of prematurity, and severe neck all correlated with increasing rates as you had decreasing gestational age by a significant amount. So we've hopefully gone over some of these complications in the hospital. We're discharged from the hospital. Now what? What are we thinking about for short-term outcomes? What do we want to tell our patients as to what to expect, right? As these patients' providers, we want to be able to counsel them on some of the short-term outcomes and also long-term outcomes once they're out of the hospital. So we're going to go over some of those. From a cardiac perspective, does anyone know how much more often preterm infants have cardiac malformations? Yeah.
5 times higher?
Actually closer to 2, but it can go up to 5 times based on the gestational age. So overall, preterm infants have twice as many cardiac malformations as term infants. And 1 in 6 infants with cardiovascular malformations are born preterm. Now, the overall birth rate for and prevalence for congenital heart defects is 116 per 1,000 very or extremely premature births. So you're putting yourself at risk with the very and extremely premature births, and on top of it, 11% of those are going to have congenital heart defects. Now, if we look at some of these charts, I have a graph here that shows, or table, that shows the prevalence of premature births among specific cardiovascular malformations, which I felt was really interesting in that it shows us a decreasing prevalence per cardiac malformation. And it also showed that realistically, pulmonary atresia with ventricular septal defect was the most common to be born premature. If we go down the list, you have the second one is going to be complete atrioventricular septal defect. The third is coarctation of aorta, and the fourth is tetralogy of Fallot. Now, this graph is interesting in that out of the data that they pulled, these were the statistics for the percent of premature infants that had these. And the very bottom on that right-hand side, you have no cardiovascular malformations was their reference. And out of this study, that's pretty consistent with what we're seeing. Approximately 10% of these normal infants are going to be born without cardiac malformations and just premature at baseline. So, why are cardiac malformations concerning? Let's talk about mortality rates in these infants. If we look at the mortality rates in these infants, the dark bars indicate an infant that did not have a cardiac malformation, and the light bars indicate the ones that did. For the OR, which is the odds ratio, it actually is the excess deaths among infants with cardiovascular malformations in each gestational group. So you're going to have infants that ironically have a lower odds ratio in the less than 28 gestational age category than those that were at term that have a significantly higher odds ratio. But if you look at the overall percent mortality rate, significantly lower in that term group, right? You just have a much higher risk relative to healthy term infants. But this also points out some of the significant mortality rates at less than 28 weeks, just at baseline, without even having that superimposed cardiac malformation. Moving on to another complication, we're going to have pulmonary. So there are three main common complications and more of a short-term outcome look that we're going to talk about today. There is respiratory distress syndrome, there is bronchopulmonary dysplasia, and then there's apnea of prematurity. So respiratory distress syndrome is caused by a surfactant deficiency, whether that's secondary to lung immaturity or disorder in the synthesis or function of that surfactant. The incidence and severity of RDS is going to increase with decreasing gestational age as well, which is going to be the trend for today. BPD is a little bit later of a respiratory complication that is commonly seen in the very low birth weight infants. It's generally defined as an ongoing need for supplemental oxygen or respiratory support at either 28 days postnatal or 36 weeks postmenstrual age, whichever comes first. Apnea of prematurity is a developmental disorder in preterm infants that correlates with an immaturity of respiratory control. Now, hopefully 2 of these 3, RDS and apnea of prematurity, will have resolved by the time they're leaving the hospital and prior to discharge. So let's talk more specifically about BPD. So with BPD, you are going to have, 2 seconds, okay. BPD is a multifactorial condition, and it involves the disruption of lung development and injury that causes inflammation and damage to highly vulnerable premature lungs. How often is this truly happening? The incidence of BPD is one of the most prevalent and one of the most prognostically more important or most important sequelae of preterm birth. In the US, it impacts approximately 10,000 to 15,000 infants annually, including approximately 50% of infants with a birth weight of less than 1,000 grams. The incidence of BPD at 28 weeks of gestation is close to 23%. 8% of those develop severe BPD. The simple definition. So this is a definition that I liked the most, and that's why I ended up including it. It made the most sense to me. The simplest definition of BPD is going to be an infant that requires oxygen therapy and or respiratory support, either at 28 postnatal days or 36 weeks postmenstrual age, whichever comes first. Now, I had to pay homage to someone that was named Jensen that was much smarter than me. So we're going to go off the Jensen definition as to what BPD is and their severity categories. This was designed in 2019. And this definition primarily actually acts off of the mode of respiratory support rather than the FiO2 that is being provided to infants as to how to define their categories. So a mild BPD is going to be requiring a low flow nasal cannula at the 36-week mark. A moderate is going to be requiring a high flow nasal cannula or some sort of positive pressure that is non-invasive. And then a severe is going to be requiring an invasive mechanical ventilation at 36 weeks. Now, what is the typical course of these kids? Typically, most infants improve gradually in the 2 to 4 months after the diagnosis has been made. Now, what exactly is that improvement? It's going to depend on what type of flow or requirement they're on at that point in time. But typically, you can expect to wean over that next 2 to 4 months. So that'll be something to know from the outpatient perspective, and they'll likely be following with pulmonary to try and wean whatever support they were discharged on. We're moving on to nutrition and growth. So from a nutrition and growth perspective, there are several things that these infants are going to be at significantly increased risk for. They're going to have higher nutritional needs. They're going to have feeding difficulties. They're going to have fortification requirements typically. They're going to require iron supplementation. They're more likely to have reflux. And then they're more likely to have issues with their bone health. Now, this image I thought was very interesting from the perspective of developmentally how preterm infants are going to be able to process nutrition. Their digestive processes are going to be on that top portion, and then their gut and innervation as well as motility is going to be on that bottom portion of the image. Now, the GI system of preterm infants shows significantly reduced both digestive and absorption capacities. They're more likely to have prolonged gastric emptying times, and then they're going to have limited intestinal motility compared to term infants. Some of those factors are going to be contributing as to why it's so hard to nutritionally replete them and also appropriately give them those oral medications and have them truly process those appropriately. A couple of things that I wanted to point out about this image while we're on it is I don't think there's a clicker right. So, at 22 weeks, which is now considered viable, a lot of these haven't really even started, right? We're looking at somewhere closer to the 28-week mark that we're really even getting into adequate secrase and maltase activity. It's not even really until 32 weeks that we're looking at decent lactase activity and being able to absorb some of these. That lingual lipase activity and some of the oral components, such as the amylase activity that you get, are going to be bypassed anyways, because all of these kids that are younger are going to end up needing a feeding tube. So you're bypassing that oral component that's going to help you digest some of those carbohydrates appropriately. Now, if you look at gastric motility, we don't even have a great amount of gastric motor activity or that small intestine activity until closer to 32 weeks, which is also when we see a significantly decreased rate of neck. We're going to see a higher rate of infants that are not processing things correctly, that are going to have higher reflux, that are going to be struggling with increasing their feeds prior to this gestational age, and that's one of the correlations as to why, or hopefully causations at this point. So, if we talk about more specifically what coordination of suck looks like, The anatomic differentiation of that human intestine is going to have completed around 20 weeks. But that functional maturation that we showed is going to be significantly delayed, closer to that 32-week mark. And if we're kind of pushing it, it looks like that peristalsis maybe starts closer to the 29-30 week. Everyone's a little bit different, but that's more of an average. That coordinated sucking and swallowing isn't really going to come until 32 to 34 weeks, which thankfully correlates with their respiratory needs typically as to when we're really truly trying to feed them. But that's also going to be something that's going to be delayed in these kids. Now, postnatal growth failure is something to think about in these children, especially in the very low birth weight and extremely low birth weight categories. 16% of extremely low birth weight infants are going to be small for gestational age at birth. But by 36 corrected age, 36 weeks corrected age, you're going to have 89% of them that are going to have growth failure. Why is that? Because of a combination of what we just showed. You're not going to have significant peristalsis, you're going to have delayed gastric emptying, you're going to be struggling to kind of increase their feeds, you're trying to get them adequately plumped and give them nutrition. But there are some things that are fighting against you. They don't even have all the appropriate enzymes to be able to digest the nutrition that you're giving them. You can't give them enzymes to do that, right? So you're fighting a couple of battles trying to accomplish this goal. But 89% of them are going to have growth failure at 36 weeks corrected. Now, if you follow up at 18 to 22 months, which is when we're taught to kind of start looking at them more based on their true age rather than their adjusted age, if you're still looking at them at that corrected age, 40% of them are still going to have weights, lengths, and head circumferences that are less than the 10th percentile. Now, growth failure specifically, the importance of this is going to be increased is going to have an increased risk for a poor neurodevelopmental outcome. So that is why we're more concerned about it, and that's why we're talking about it today. Specifically how to get around it. We're going to talk about fortification a little bit and why it's important. You're going to need fortified formula for a lot of these kids due to the decreased absorption components and also the poor suck on a lot of these and poor gastric motility that's going to limit how much you can truly give them. So you're fighting that battle of how much can I truly give versus how concentrated can I give this formula to try and get some of this appropriate nutrition into them. After discharge, that enriched post-discharge formula should be continued for approximately 9 months. And that's just an average, but realistically, a lot of these kids, because of that growth faltering, are going to need supplemental formula or some sort of fortification. Now, one of the big things to talk about with parents is going to be reflux. There's been there have been a few studies actually that show that preterm infants are more likely to have reflux, and it has to do with the lower esophageal sphincter and some of the lack of coordination that they're more likely to have. Realistically, this is still physiologic. They will eventually outgrow it. There's no recommendation to start medication, but it is something to be aware of that it's more likely to last for a longer period of time in these than for term infants due to that immaturity. We talked a little bit about malabsorption. We'll go a little bit more into depth as to what specifically we're more concerned about after discharge that they're not absorbing. One of the reasons that you recommend preterm infant formula for them is that they are going to need increased minerals in their formula. They are more likely to need calcium as well as magnesium and phosphorus in their formula due to their bone health. They are at an increased risk for osteopenia and fractures due to their loss of that time period while they were supposed to be intrauterine of that accretion or that component of pulling out the calcium and the phosphorus and the magnesium from mom that typically occurs in the 3rd trimester. So they're going to have significantly less of those deposits, and they're going to require formulas that specifically have that additional calcium, magnesium, and phosphorus for growth and also for their bone health, which a lot of term formulas don't have. Specifically, soy formulas do not have that appropriate amount of those minerals. Okay. So talking about some of the other things that we want to supplement, we're going to talk about iron supplementation. That is something that a lot of parents really don't like giving their kids. They either don't like the taste of it or it makes them constipated. So why do we need iron supplementation? The majority of the total body iron present at birth is actually accumulated in our third trimester, once again. This process of accumulation of iron actually, for a neonate, tries to maintain approximately 75 mg per kg of iron based on their body weight throughout the third trimester. So why is that really important? They have an appropriate percentage. They have the 75 mg per kg of iron that they should. But if you have an extremely low birth weight infant who weighs 500 grams at birth, they only have 37 mg of total body iron versus an AGA, or appropriate for gestational age term infant, who weighs 3.5 kilos is going to have 260 mg of total body iron. That's a big difference. And that's something that is difficult to replete quickly, especially with their decreased absorption abilities. So recommendations post-discharge are going to be a dietary infant intake of 2 mg per kg per day for infants with a birth weight of 1,500 to 2,000 grams. That's just the general recommendation. You can go up and down from there. But iron supplements and iron fortified formula should be continued for the first 6 months at minimum, possibly the first 12 months, depending on their nutritional intake, which I would argue we don't have great nutritional intake as a population, so they probably should continue to 12 months. Okay, so moving on from iron supplementation, we're going to talk about neurologic concerns. So hopefully by discharge, your babies don't look like this. That is a photo courtesy of Dr. Klein. Stole that, I'm sorry. Okay, hopefully they are not looking like that by the time you see them, but they are at increased risk for having an intraventricular hemorrhage. Intraventricular hemorrhages occur in the first 24 hours typically of life, but in approximately 20 to 40% of the cases, they can still have persistent bleeding and further progression of that hemorrhage for the next 3 to 5 days, which is why we typically get our ultrasounds at closer to 7 days of life. The incidence rates of intraventricular hemorrhages are also, just like our trend for today, are going to increase with decreasing gestational age. So that is something just to keep in mind. For a 30 to 32 weeker, the odds of them having severe, which is grade 3 or greater, intraventricular hemorrhage are only 0.5 to 2%. But if you look at a 22 weeker to 23 weeker, their odds of having an intraventricular hemorrhage are 30 to 45%. Okay, so what does that mean for these infants? What happens after they get an intraventricular hemorrhage? Some of them are going to have post-hemorrhagic ventricular dilation. That is also referred to as post-hemorrhagic hydrocephalus, depending on who you talk to. And it's the major acute complication of severe intraventricular hemorrhages. And the risk for that is going to increase with the higher grade that you have of intraventricular hemorrhage. So if you look at grade 1s and grade 2s, you're less likely to have any of these PHVDs. But if you look at grade 3 or grade 4s, you're at significant risk for having any sort of complication with that. How do we manage this? So for approximately 5 to 15% of these neonates that have post-hemorrhagic ventricular dilation, they're going to need some sort of permanent ventricular shunt. Why is that important? It has a significantly higher risk, any infant does, of having neurodevelopmental disabilities compared to those that do not require permanent shunting. So anyone that ends up having a shunt is going to be at significantly increased risk, despite the fact that they might have the same amount of intraventricular hemorrhage as someone else. That hemorrhagic ventricular dilation is going to put them at risk. Just as a reminder, these are what the grades look like, just for context. So we have grade 1 on the right, grade 2 further down, and then grade 3 and grade 4 should have similar outcomes in terms of percentage rates. Now, something that I personally correlate with neurology is going to be ophthalmology. So retinopathy of prematurity is going to be one of the things that we're going to talk about today. One of the challenges following preterm birth is going to just be their eyes in general in terms of development and growth. So Ophthalmologic challenges are going to be extremely common, especially in that extremely low birth weight group. So those that were less than 1,000 grams, they are 3 times more likely to have a vision of less than 6/60 than those that were born in term. At term, our eyeball is pretty well developed compared to the rest of the body. The most active stage of development of our eyeball is going to be somewhere between that 6-month mark of gestation and then birth. So term for these kids. But by the threshold of viability at 22 weeks, many of the structures, such as the uveal tract and the sclera, are near full development. The ones that are not are going to be the cornea, the lens, the retina, and the macula. Those haven't developed at 22 weeks. That's one of the reasons why we're at significantly increased risk for any eye problems or concerns for these kids. In a prospective study that was carried out over a 10-year time span, the rates of severe ROP, or retinopathy of prematurity, were shown to decrease significantly by that gestational age increase. But 43% of these children that were born between 22 weeks and a little bit before 25 weeks were noted to have severe retinopathy of prematurity. Talk about illness. That's something that a lot of people forget about and also are still concerned about. So I pulled up a study that was done at a single center academic freestanding children's hospital that analyzed the difference between preterm infants and term infants that were evaluated for sepsis at 0 to 60 days of life. Realistically, preterm and term infants had similar bacterial infection rates, but they had a higher rate of bacteremia. They were more likely to have bacteremia at 5.9% versus 2.5%. They also required the ICU significantly more often, at 32% versus 5%. And they were more likely to get inflammatory markers done and chest x-rays done despite the lack of difference in lumbar or blood culture rates. Preterm infants had a lower white blood cell count and ANC, so that's going to be something to keep in mind for our kids that are preterm that are having a septic workup, because the newest febrile guidelines are going to include that ANC of greater than 4,000. So it's a little bit harder to extrapolate from. What about long-term outcomes? So we're going to talk about long-term outcomes. Same topics pretty much, but just a little bit further out. What are their cardiac expectations? So there's actually an inverse association between birth weight and deaths from cardiovascular disease in adults. Now the interesting thing is why? Why specifically, if they don't have a known cardiac malformation, why are they having this increased risk? So in preterm infants, you're actually more likely to have increased systolic and diastolic pressure as you get older, reduced vessel size and density, arterial stiffness, endothelial dysfunction, and then a decreased left ventricular diameter and an increased interventricular septum defect. Oh, sorry, thickness, not defect. There was a population study that looked at 4.1 million people. And if you looked at preterm birth and extremely preterm birth, you had an association with 1.4 and 4.7-fold times the risk of having new onset heart failure relative to term births. So you're going to have a significantly higher risk of having long-term complications in these kids. Now, let's look at this. Bear with me, it's kind of a busy slide, but I'm just going to walk over here. So, we're going to start with the lungs. Realistically, if you're born premature, you're going to have immature lungs, you're going to have an immature cardiac system. Realistically, both are anatomically pretty developed, but due to the increased FiO2, you're more likely to have higher concentrations of reactive oxygen species. You're more likely to develop BPD at that 36-week post-menstrual age or that 28-day mark. Because of that, the reactive oxygen species are likely to alter the differentiation and proliferation of cardiac myocytes, which are going to long-term create issues from a cardiac perspective. In addition to that, you're more likely to develop pulmonary hypertension because of BPD. So that's also going to throw our cardiac perspective off. And we're more likely to have alterations in function, both from a right ventricular structure and a left ventricular structure. You're going to have decreased left ventricular mass, which ultimately affects our diastolic as well as our systolic, And then you're going to have an increased right ventricular mass, but a decreased right ventricular volume. So that's going to create some dysfunction there and lead to heart failure eventually. Now, we'll get to this a little bit later, but BPD also correlates with a higher component and a higher risk of having some sort of reactive airway disease diagnosis, which ultimately, if we're assuming we're getting a little bit older, could lead to COPD, which would exacerbate the pulmonary hypertension and create additional heart failure concerns. Now, for right now, we'll just avoid this side. But realistically, there are some other concerns in terms of metabolic syndrome and increased risk from a nutritional standpoint that could increase our risk for ischemic heart disease and heart failure. Now, the next slide I thought was also very interesting. It's also a little busy, so I'm sorry. But it showed us the difference between adaptation to early extrauterine exposure and then how you go from that to physiologic compensation and then physiological maladaptation as an adult. Realistically, the maladaptation as a neonate is going to long-term impact some of these structures that initially just cause functional changes, then it leads to dysfunction, and then just structural inefficiency at the end towards adulthood, which is one of the reasons why they have increased risk. I'll share these slides. I think it is a little bit busy to talk about at this point in time, but I did think it was interesting to look at some of the decreased heart size, that increase in right ventricular mass, and how it long-term has an outcome on increased blood pressure and that increased rate of heart failure. So what are some of our other expectations? We talked a little bit about cardiac, let's talk about pulmonary. Recurrent wheezing is very common in children with BPD. It typically starts in the preschool years and continues to adulthood. You are also more likely to have airway hyperresponsiveness if you have any sort of BPD complication. And adolescents, as well as adults, are more likely when they are born preterm to have impaired exercise capability, airflow limitations and air trapping, as well as decreased alveolar gas transfer. There was a study done in France, it was called the Epicure study, that was of children born of less than 26 weeks. And 25% of those children had a diagnosis of asthma at age 11, purely based on gestational age. Now, 56% of those kids had abnormal spirometry. They're just at increased risk purely due to that gestational age and some of the interventions that are required to keep them here. Now, there are a couple other studies that were performed, and the odds of being assigned an asthma diagnosis is 3 to 4-fold more likely in children that are born less than 32 weeks relative to the general population. Something to keep in mind. If we talk about additional concerns, pulmonary hypertension is one of the complications that we need to keep in mind, secondary to BPD. It develops in approximately 20 to 40% of infants with BPD, and it is a very high risk in premature infants, specifically the very low birth weight, the very premature, and any that have cardiac abnormalities. So, recommendation-wise, at minimum for any infant that has moderate or severe BPD would be to screen for pulmonary hypertension via echo. Tracheobronchomalacia is an abnormally compliant collapsible central airway. And realistically, this is less common than it was years and years ago, but it's still something worth talking about because it's still present to this day. It's typically a consequence of barotrauma. It can be a consequence of recurrent infection. It can be a consequence of endotracheal intubation. All of those things can happen when they're hospitalized, but it was previously more prevalent with some of the older interventions. Now, one of the things that I want to talk about and something to think about is going to be rehospitalization risk with these parents. They are up to 50% of the children that have BPD require rehospitalization in the first 2 years of life due to respiratory illnesses. So when they get sick, they are more likely to require hospitalization secondary to respiratory illnesses. What are the guidelines and what are the expectations that we can tell parents because of this? So From a general guidance perspective, some of the recommendations are close adherence to immunization schedules, specifically with RSV vaccines, COVID vaccines, flu vaccines. Additionally, they recommend to individualize whether or not you feel like it'd be appropriate for these children to go into daycare. That's not always possible, but it's one of the recommendations. Strict avoidance of tobacco smoke, as well as any sort of smoke exposure, is also recommended. There were studies done to see if any sort of intermediate measure could be helpful, and that was found to not be helpful. So it's strict avoidance. Other things to think about is going to be as they get older. You want to give them anticipatory guidance that they should not be smoking as teenagers because they are more likely to have consequences of that than the general population. We move on to growth and nutrition. Body composition differences occur in these preterm infants. Now, it's hard to say how much as to realistically their body composition is different, but they were found to have a lower lean body mass, an increase in body fat, and a higher risk of developing dysglycemia in the 4th decade of life, as well as a decreased insulin sensitivity. Now, why is that? The thought process behind it is that infants develop adipose tissue essentially in the 3rd trimester of pregnancy, which once again, most of these kids are not experiencing the majority of the 3rd trimester of pregnancy. So the thought process is that disturbances in that adipocyte tissue development actually changes the function and that it's less effective. And so that's more noticeable in the later years. And that's one of the reasons why they think that that's the case. Some of the neurologic expectations. So I didn't have very much to put on here because it was going to just get too in-depth as to shunt failure and things that could happen that don't always happen in these preterm infants. But if you have a child that ended up needing a shunt, likely secondary to hydrocephalus of some perspective, they're more likely to have a worse prognosis from that neurodevelopmental standpoint that we talked about. And they are also more likely to have a high rate of CP and disability. Shunts are going to have a high rate of failure in the first 2 years of life, so any sort of neurologic concerns that your patients are bringing up should be evaluated in that first 2 years. Some developmental expectations that we'll talk about briefly are going to be that preterm infants are at a significant risk for deficits in all these categories, which is pretty much every category, if you think about it. However, they are most commonly noted to have specific learning disabilities in reading, math, and in spelling. There's also been described this preterm behavioral phenotype, which I found really interesting, and it's anxiety, inattention, and social withdrawal, which to me, if you put those 3 together, I think also accommodates to or accounts for some of the increased autism diagnoses that we're having more recently. So it's just kind of interesting to think about some of those preterm behavioral phenotypes and differentiating truly if they are going to have any sort of improvement throughout their lifetime with that anxiety, inattention, and social withdrawal, or if it is truly something that is just not going to improve. This is a little bit of a busier slide, but I wanted to talk about it because it was the longest study that has been done so far on neonates that were born preterm. So in the New England Journal of Medicine, they actually published an article that looked at Norway children born between 1967 and 1983 and followed them all the way through 2003. And they looked at some of the complications and things that they went through to see what these expectations into adulthood were going to be. Now, keep in mind, we talked about the history of neonatology. In 1967, the mortality rate was significantly higher for these 1 kilogram infants, right? You're not looking at great outcomes. So keeping that in mind, we're going to look at this. They broke it into gestational age categories. I listed out how many patients they had in each category, purely just for knowledge perspective. But the infants who survived to adult life increased with that increasing gestational age. So it was only 17.8% for that 23 to 27 week category. But it was 96.5% for the 37 week or later. Among the survivors, you had a significantly increased risk of having cerebral palsy, a significantly increased risk of having mental retardation, and a significantly increased risk of having to have a disability pension, which I personally didn't know very much about what a disability pension was going to be in Norway, so I looked it up. It is the person that qualifies for disability by the age of 18 years, and it's due to them being permanently unable to work by a reduced percentage of 50% or more. So it's their capacity to work, and it means that it's reduced by 50% or more. Now, if we look at the longer term ophthalmology expectations, they are more likely to have that subnormal vision. They're more likely to have all of these concerns. And so realistically, a pediatric eye care specialist is recommended to have screened them by 9 months to 12 months, and then again at 2 to 3 years old because of those increased risks with that delayed development. So, let's talk about summary. Some of the things that I want you guys to take away from this talk. Preterm infants have twice as many cardiac malformations as term infants. BPD is defined as an infant requiring oxygen therapy and or respiratory support, either 28 postnatal days or 36 weeks postmenstrual age, whichever occurs first. Premature infants require enriched formula or fortification to provide the adequate calories for growth and minerals, specifically that calcium, magnesium, and phosphorus to prevent osteopenia. An inverse association between a birth weight and deaths from cardiovascular disease occurs in adults. And then adolescents that are born premature at increased risk for impaired exercise capacity, airflow limitations, and air trapping, as well as decreased alveolar gas transfer. Okay, so I have 3 questions for us. If you guys could do them with me. I can read this out loud. I am sorry if I miss words. Okay, we have a 9-week-old female that was born at 35 weeks post-conceptual age in the NICU, who is ready for discharge home. She was born at 26 weeks, estimated gestational age weighing 750 grams. Her delivery was precipitated by maternal chorioamnionitis. After initial management with nasal continuous positive airway pressure, or CPAP, due to increasing oxygen needs, she required endotracheal intubation with delivery of 1 dose of endotracheal surfactant, and on the 2nd day of delivery, after delivery, and ongoing volume-regulated mechanical ventilation. Over the next week, her respiratory support requirement declined, and she was put back on nasal CPAP with 25% oxygen. By 4 weeks of age, the infant required 0.5 liters of oxygen via nasal cannula. On the day of discharge, she required 0.25 liters of oxygen via nasal cannula. She is taking full feeds orally and gaining weight well. The parents are counseled regarding their child's risk for long-term respiratory effects and neurocognitive morbidity at 18 to 24 months corrected age. Of the following, this infant's most predictive factor for these outcomes is A, delayed surfactant administration, B, nasal cannula oxygen requirement at discharge, C, oxygen requirement at 28 days after birth, or D, very low birth weight.
D.
So, ironically, it is technically both, but they relate on the fact that the long-term respiratory effects were more likely secondary to a nasal cannula oxygen requirement at discharge. So, it's actually supposed to be at 28 days after birth. I put that in wrong. But the reason why they ended up saying that is actually because of that severity category. So if you look at that criteria, they relayed that long-term outcomes are more correlated with the severity categories in terms of that BPD risk. And that's the most prognostically significant. Okay. We have a 2-month-old infant who is undergoing a routine health supervision visit. He was born at 33 weeks gestation with a birth weight of 3.96 pounds or 1,800 grams. He stayed in the neonatal intensive care unit for 12 days, requiring positive airway pressure and oxygen support for the first 3 days after birth and phototherapy for hyperbilirubinemia. He was fed cow-based premature infant formula via nasogastric tube for the first few days, then orally. His discharge weight was 3.8 pounds. The infant's mother recently switched him to a soy protein-based formula owing to fussiness and spitting up. His weight today is 7.05 pounds, and his physical exam findings are normal. The mother is counseled regarding the use of soy protein-based formula for this infant. Of the following, the best information to provide this mother is that the use of this formula, A, does not provide adequate minerals, B, is appropriate because of weight gain, C, may help with colic and reflux, or D, may help with cow milk protein allergy. Yep.
Minerals or protein?
What?
Is it minerals or is it the protein?
The minerals.
Calcium and phos.
So realistically, we talked about the calcium, the magnesium, and the phos to prevent osteopenia, and the soy protein-based formulas do not have that, or at least not sufficient amounts. Last question. A 3-month-old preterm infant is seen in the office for a health supervision visit. The family has been struggling financially. They have been unable to afford infant formula and have instead been giving the infant whole cow milk. Of the following, this infant's diet puts them at increased risk for A, iron deficiency and anemia, B, kidney injury, C, poor growth due to insufficient calories, or D, vitamin D toxicity. A, iron deficiency anemia. So realistically, with cow milk, just in general, that whole milk is not going to have enough iron supplementation, and they're already at risk for iron deficiency anemia. So you really need to have that fortification with iron with the preterm formulas. Okay. Any questions? I think we finished 3 minutes early. So.